So we're going to continue on with the thyroid gland goiter. Um, this is something that you're going to see a lot, so it's good for you to know. A non-toxic goiter is simple, colloid, multinodular, and what you're going to see is you're going to see like just a really heterogeneous enlarged gland. And there's going to be like a lot of nodules, but you can't like just you would be working forever to distinguish each one of them with measurements. So it's like multiple nodules. There's going to be calcifications, fibrosis, cysts. It just is not going to look pretty. You guys are scanning your thyroids right now. That's smooth, very just like homogeneous pattern of a normal thyroid. This is not going to look like that. You're going to know something is wrong right away, because it's going to be enlarged. It's going to be heterogeneous. It's going to be lobulated. Some can double in size to massive enlargement. A lot of the a lot of the people that have like really massively enlarged thyroids can fill their thyroids. They can fill it. Sonographic features associated with increased risk for malignancy is hypoechogenicity, microcalcifications, which you're going to learn a lot about microcalcifications because they seem to be like a theme in malignancy with both thyroid and breast cancer. Increased vascular flow, like I've been saying, cancer loves blood flow. So it's going to want to do a low resistance blood flow. It wants all the blood flow and irregular borders. And those are going to be like your major things to look for like a malignancy. So if we're looking at these pictures here, A, B, C, D, look at F here. If you're looking down at that, look how I hate to say a thyroid's ugly, but it's ugly. That's ugly. You can see that it's multilobulated. There's little calcifications, little cysts. It just looks not pretty. It looks unhealthy. This is an image of both the right and left lobe with the isthmus, and the isthmus is even enlarged. So you're going to have, this is another image of like a sagittal view of the thyroid, and you can see that it's just very enlarged, heterogeneous. It's not its normal, like homogeneous echo texture. In E here, you're also going to see you could see eggshell calcification nodules within the goiter. So there's going to be multiple different ways that the goiter can appear, but you'll definitely know that it's not a normal thyroid. So why do we do an ultrasound on these goiterous patients? So to differentiate thyroid gland enlargement from adipose tissue or muscle, confirm the pattern or location of enlargement and extensions, provide the correct interpretation to correlate varying clinical impressions, objectively document volume changes in response to suppressive therapy and thyroid hormones. So they might go on some thyroid hormones. You might follow them every 3 to 6 months to see if their thyroid has shrunk, and monitor patients undergoing long-term treatments with lithium for mental illness, bipolar depression, schizophrenia, because lithium can cause these. Thyrotoxicosis or hyperthyroidism is a hypermetabolic state caused by elevated T3, T4. Hyperthyroidism is hyperfunction like Graves' disease, which is autoimmune. And the thyroid could look like once the person asks in their discussion, can we diagnose hyperthyroidism and hypothyroidism by how a thyroid looks? And that's was a really good question because you really cannot. However, there are some autoimmune disease. There are some diseases that are either hypo or hyperthyroidism that can cause enlargement of the gland. And so particularly like Graves' disease, which is occurs in makes the thyroid hyper, or elevates the T3, T4. They could potentially have an enlarged gland, but another thing to look at is the thyroid could be hypervascular or like a thyroid inferno is what they say. So like, um, you put normal color on, you're going to see some color with thyroid. I want you to do that in your abdomen class, if you haven't yet. And put thyroid, you're going to see like normal flow. You're going to see some flow. With a thyroid inferno, it's just like you're going to put color on. It's just going to be like crazy. It's going to flash all over the place. It's going to fill the screen. You're going to be like, whoa, do I need to like turn my PRF up or turn the color gain down? But no matter what you do, it's just hypervascular. And so that that's a thyroid inferno, and there's probably something going on with that. So let's look. I like these pathology boxes because it can kind of, it's good to know this kind of stuff. So why would a person have hyperthyroidism, cause of primary and secondary? Well, there's multiple reasons. Sometimes they don't know for sure, but some of the causes are Graves' disease. Toxic multinodular goiters can do that. A hyperfunctioning nodule, follicular thyroid carcinoma, which is rare, thyroiditis, or ingestion of exogenous thyroid hormones administered for hyperthyroidism. So they could go the wrong way and prescribe too much, and it can cause hyperthyroidism. Causes of secondary hyperthyroidism would be secretion of excessive amounts of thyroid hormone by ectopic thyroid arising in ovarian teratomas. Oh, yes, you guys remember the dermoids, don't you? So, those dermoids, they have like teeth, they have hair, they have all this kind of stuff, but they also can have thyroid tissue. And so if there was excessive thyroid tissue within these like teratomas, causing extra hormones going into the brain, that can cause hyperthyroidism. So clinical manifestations, increased cardiac output and decreased peripheral resistance. So tachycardia, they're going to have higher heart rates. They could have an enlarged thyroid gland. GI, weight loss, increased peristalsis, leading to diarrhea, nausea, vomit, anorexia, abdominal pain, excessive sweating, flushing, warm skin, heat tolerance, muscular weakness, nervousness, restlessness, short attention span, fatigue, insomnia. One of my patients that had hyperthyroidism felt like she was like in a constant panic attack, is what she said. She's like, I just have so much anxiety. I feel like my heart is racing. I'm sweating. I like can't calm down. It's just like this restless feeling. And it's because this thyroid is producing too much hormones. Can also skip your periods. And so here's some images of increased vascularity, especially on D. You can tell that that is just like not normal flow for like a normal thyroid. It's excessive. Look at B. Like that's excessive flow. So it could be that. So let's talk about hypothyroidism again. So most common thyroid function disorder, you're going to hear all sorts of people having hypothyroidism. If you're tired, if you're fatigued, if you're having trouble with weight gain, a lot of the times your doctor is going to like get labs just make sure that your thyroid is functioning normal, because these are a couple of reasons why what happens when you have hyperthyroid, you're like you don't have enough thyroid hormones going in. So most common cause is iodine insufficiency, lymphatic thyroiditis, or Hashimoto's, which if you guys have heard about Hashimoto's, it's a autoimmune disease, can cause hyperthyroidism. Secondary cause, less frequent, including pituitary and hypothalamic disease. So here are some reasons why a patient would have primary hypothyroidism. The most common reason is Hashimoto's thyroiditis, or postpartum thyroiditis, like inflammation of the thyroid after birth. So a couple of the pathologies of hypothyroidism. Heart rate results in lowered cardiac So just totally opposite than the hyperthyroidism. They're going to have I've heard, and I don't know if this is true, but a lot of people that do have hypothyroidism are cold a lot. So the endocrine system, they're going to have increased TSH production in primary hypothyroidism. Um, they could have increased serum prolactin levels, leading to galactorrhea, which is basically milk coming out of your breast again. Decreased rate of cortisol, constipation, weight gain, fluid retention, just totally different than hyperthyroidism. Decreased protein metabolism, edema. We have dry, flaky skin, dry, brittle head and body hair, reduced nail and hair growth, slow wound healing, and cold skin. That have muscle aches and stiffness, slow movement, slow tendon jerk reflexes, decreased bone formation, confusion, syncope, slowed speech and thinking. That's like really bad but a lot of people also say brain fog is something that happens in hypothyroidism. Lethargy, headaches, hearing loss, night blindness, slow clumsy movements. Yeah, so it's not great. It's not great at all. So who knew this little gland in our neck could cause all this issues, right? Like, isn't that one thing we've learned in both abdomen 1, abdomen 2, OB1, OB2 is like, man, it takes every single part of this body to function for us to like be healthy. And if one thing is off, it can really make everything else just be sick. So I scan a lot of people that have Hashimoto's thyroiditis. So you can think when you Hashimoto's, you're going to have hypothyroidism. So they're going to have a coarse texture, heterogeneous, multiple ill-defined hypoechoic areas separated by thick fibrous strands. It just looks like an ugly thyroid. It just does not look good. And best indication of a diffuse enlargement of an isthmus is a measurement of greater than 1 centimeter AP. And also hypervascularity with this too. So there's no exact way, but look at this. Look at this nasty thyroid. It looks like almost a kidney. That is not good. Sometimes you almost have to like use an abdomen probe on these kind of thyroids because you can't get the whole thyroid, the sagittal thyroid within the image with a little small parts probe that you're using. So you need like a curvilinear array to get it all. But these are all the different appearances of like a gland that has hyperthyroidism. And you can see that there's increased vascularity in this too. So you can have gland inflammation too. So I don't know, there's so many different types. So I don't really feel like you need to know all of these, but just kind of like go through, know that it could happen after having a baby. Hashimoto's is a um, inflammation area. Just kind of look this over just to know, but I'm not going to be testing you on all these different types. Just know what it is. This is an image of a thyroid with like inflammation. So it seems like it's swollen almost. So the second most common endocrinopathy in women of reproductive age is when like pregnancy, when they have thyroid issues. The maternal physiological changes during pregnancy, increased TBG, increased HCG, and this can cause the thyroid to kind of tweak out. They do always do thyroid levels on you when you are pregnant, just to make sure it's in the right spot. And if it's not, if you have hypothyroidism or hyperthyroidism, they'll want to start you on medication for that because it can definitely hurt the baby if your thyroid's off. So a little bit about like thyroid carcinomas. Most nodules are benign, 5 to 6.5 are malignant. Papillary carcinoma is the most prevalent, followed by follicular and medullary anaplastic and Hürthle cell cancer. So suggestive criteria: if there's solitary one nodule, if it's a younger patient, if they have a history of radiation exposure, if it's a male, it might require a fine needle aspiration where they do a biopsy, which really, really looks like it hurts because they don't really numb it when they go in there. It just like it's not good. It's not good, guys. Um, but I guess you got to do what you got to do. Um, but I really like being in the room because you help with these, being a sonographer. If you work in the hospital or you work with a doctor who does a lot of these, and yeah, it was my least favorite things to do. So anyway, like sonographic appearance, what are some characteristics sonographically that would make it increase thyroid cancer risk? Hypoechonicity, entirely solid, microcalcifications, hypervascularity, incomplete or absent halo, ill-defined margin, shape is tall, greater than wide, local invasion of lymph adenopathy, and elasticity indication of increased tissue stiffness and compared to normal tissue. So know those. I'm going to be testing you on those. Associated with low thyroid cancer risk, hyperechoic or isoechoic cystic elements, large coarse calcifications, eggshell calcifications, perinodular hypervascularity, so like around or comet tail shadowing. Those are associated with low thyroid cancer risk. Now I want to go scan my thyroid to make sure I'm okay. But yeah, know those characteristics. Those are going to be something that you need to be tested on. So elasticity describes a mechanical tissue characteristic that prevents displacement of stiffer tissue when placed under pressure, such as with compression from an ultrasound probe. Elastography evaluates stiffness. Malignant nodules tend to be more stiff. They don't move as good. So the pathology of the thyroid gland, papillary carcinoma, this is going to be the most common. It accounts for 75 to 85% of thyroid. And actually, it's a younger cancer. It's 20 to 50 years of age. It's most prevalent in females, and it's the least aggressive kind of thyroid carcinoma. I know maybe two people that have had thyroid cancer and then had their thyroid gland taken out, and they're doing good. I think like multiple people have told me that if you're going to have a certain kind of cancer, thyroid cancer is the kind of cancer to get, which I'm like, I don't want any kind of cancer. But if I was going to get one, probably thyroid cancer because it doesn't metastasize. And yeah, it can be cured pretty easy. So clinical presentation, painless, palpable nodule, enlarged cervical lymph nodes, cervical lymph adenopathy in the absence of papillary nodule. So if you can feel your lymph nodes, but you can also feel a nodule if you're going through your thyroid. I'm doing it right now just to make sure. You could potentially like there could be a risk of having papillary carcinoma. Now the one of my people that I knew actually was a sonographer, so she found it herself, which I don't know how I would feel about that, but I guess they got taken care of earlier that way, so that's good. Here are a couple of images of it. Some of them are pretty indiscreet, others are not. So I think B is kind of hard to see. If you look at me, it's very indistinct. It's not easy to see. So they can be kind of stinkers. A, of course, is a lot easier. C is easy. E is easy. F is kind of a small one with shadowing. So follicular carcinomas are the next most common kind, and they're account for about 10 to 20%, and 20 to they're also young cancer, 20 to 50 years of age, more prevalent among females, increased incidence in geographic areas of endemic goiter or iodine deficiency, minimally and widely invasive based on extension of tumor through capsule. Hurther cell is a group with follicular thyroid cancers, but more aggressive. It's slow growing, enlarging, and painless nodule is the clinical presentation of the follicular carcinoma. Here is B is a fine. C, definitely you can see that. You can see a nodule with little calcifications around it. Here, B is, there's the needle right there. They're doing a fine needle aspiration of that one. Medullary carcinomas is the next one. So no more than 5% of all thyroid carcinomas. So these sonographic appearances are hypoechoic, microcalcifications, lymph nodule metastasis, and hepatic metastasis. So, okay, we do not want this kind of cancer, but this is why, like, it's less than 5%. Papillary carcinomas are mostly what we're going to see, so they don't metastasize as much. But we definitely do not want a medullary carcinoma because it seems like they are aggressive and they metastasize. So this is not what we want. So there is going to be like a mass in the neck, sometimes associated with dysphagia and hoarseness. So, and they're going to have like symptoms from endocrine secretion. So anaplastic carcinomas and lymphomas, they're undifferentiated. Less than 5% of all thyroid malignancies. Females are at greater risk, 60 to 65, aggressive with widespread metastases. Oh my goodness, I did not like this one. Um, most arise from chronic thyroiditis with Hashimoto's, can cause lymphoma. So sonographic appearance of this is a large solid hypoechoic mass with compression of thyroid parenchyma or infiltration of the thyroid parenchyma, hypervascular, lobulated cystic necrosis. So yeah, it's like solid mass that is a single mass. Those are the ones that probably are going to be a little bit more cancerous. So metastasis, like when it comes to the thyroid from a um, origin of somewhere else, is very infrequent, but through the blood route is how it would get there. Through melanoma, breast, lung, and renal carcinoma. Because you remember melanoma, breast, lung, and renal cell carcinoma, they love to metastasize. So they're going to try to get every place they can. So cancer diagnosis is made from cystology evaluation. So you're not going to be able to diagnose even what kind it is, but your job as a sonographer is to know that there is something there and to measure it, to put color on it, to be able to see it. Because if you don't take a picture of it, the radiologist isn't going to know that it's there. So it's very important that you're paying attention when you're doing these thyroids, that you're looking through it, that you're looking for indistinct little margins, you're looking for little masses that want to hide, and that you're really taking your time because it's important. Because if you don't see it, they're not going to see it. So once you do see something, what you're going to do is you're going to take images of it. You're going to take measurements, color flow, identify where it is in the thyroid. And that's all you can really tell. You can't tell what kind of, if it's a papillary carcinoma or medullary carcinoma, you can't tell that from sonography. There's like maybe a couple of things that are different for each one of those sonographically apparent, but you can't definitely tell that. Where you're going to tell that at is like through a biopsy, fine needle aspirations. So indications and guidelines are strongly considered when a nodule has microcalcifications greater than 1 centimeter, when the nodule is solid and almost entirely solid, and when the nodule has coarse calcifications, and then the nodule is 1.5 centimeters. So effects may include bleeding, hoarseness, infection, or seeding of thyroid cancer along the needle track. So there is some stuff that can go with final needle aspirations. Um, some side effects, of course, with anything, but yeah, you got to know so they can figure out what to do. So you're not really gonna refuse the biopsy. So the protocol, it's an outpatient protocol, um, outpatient procedure using standard sterile techniques, position patient for the thyroid examination, apply ice to restrict blood flow and help anesthetic. They use a 25 gauge needle. You'll be setting all of this up for them. And parallel to the transducer phase, visualize needle entering and moving within exiting the nodule. Some doctors do it by themselves. Some have you hold the probe while they do it. Limitations is a high repeat rate. Sometimes they don't get what they need, which I would be so mad. I'd be like, no, this is ridiculous. I'm not doing this again. I would not be a good patient, man. I would not. But the cancer diagnosis is 1 every 20 biopsies. Okay, so which nodule pathology is associated with the increased vascularity term thyroid inferno? And that's Graves' disease, which is a common feature of a malignant mass, internal Doppler pattern. Which nodule would most likely present as an oval, circumscribed, and demonstrating a halo effect? That's going to be an adenoma. And we are going to stop for today. Thanks for hanging. I'll see you next time.